Welcome, everyone. Thank you for taking time out of your busy schedules to join us today at the Institute for Safe Medication Practices for the last of 3 programs in a series dedicated to drug diversion and patient safety. Today's program is entitled Engaging the OR and Procedural Areas to Mitigate Risk with Controlled Substance Medications. My name is Susan Paparella. I'm a registered nurse and vice president at Ismp. I will be your host for today's program. We would like to thank Fresenius Kabi for their generous support for this entire 3-part webinar series. Workflow processes in the OR and procedural areas can contribute to an environment that's vulnerable to drug diversion. Broad access to a variety of medications, delays in documentation, rapid patient turnover, and limited practitioner oversight can make detectability difficult. Today, our faculty will share how to engage professionals in implementing best practices in the OR and procedural areas for controlled substance management. They will illustrate how through leadership and collaboration, organizations have implemented safeguards and created a culture of awareness and accountability in all levels of the organization, providing effective drug diversion prevention and response. Next slide, please. Our learning objectives for today include cite the scope and impact of diversion issues within ORs and procedural areas, apply 2 interventions to minimize diversion of controlled substances in the OR and procedural areas, and engage key stakeholders in waste reduction through the implementations of the diversion management plan. Some additional quick housekeeping items. This program is being recorded and will be available on the Ismp website. Handouts for today's program can be found using the link provided in the reminder email you received earlier today, as well as in the Zoom chat box. All attendees are in listen mode only during the presentation. Feel free to ask a question by accessing the Q&A or chat functionality on your toolbar. If the speaker doesn't address your question during the program, we're planning to have some time at the end for Q&A. Before we start, let me introduce our faculty. Our first speaker is Dr. Edward Pollock. Dr. Pollock is a practicing anesthesiologist and chief quality officer for Henry Ford Hospital and Henry Ford Medical Group. His work focuses on patient and staff safety, measurable quality, risk, infection prevention, and accreditation. Prior to his current role, Dr. Pollock served as a patient safety officer and medical director at the Joint Commission and has nearly 2 decades of experience in a variety of roles, including patient safety officer at Beaumont Hospital in Royal Oak, Michigan. Our second speaker for today is Dr. Ryan Hamschild. Dr. Hamschild is an experienced director of pharmacy at Emory Healthcare and Winship Cancer Institute, overseeing profit and loss responsibility, pharmacy operations, clinical services, formulary management, payer and health plan contracting, and medication use across one of the nation's largest academic integrated health networks. Ryan provides strategic direction within oncology and non-oncology disease states, infusion and specialty pharmacy services, and the expansion of clinical services through the treatment pathway development. He serves as an editorial board member at the American Journal of Managed Care and board member for both the Institute for Safe Medication Practices and the Center for Biosimilars. Full bios are available for both of these faculty on the Ismp website. So again, welcome to both of our speakers. And Dr. Pollock, can you please go ahead?
Thanks, Sue, and thanks to Ismp and my co-presenter, Ryan Hamschild. Really appreciate the opportunity to speak and talk about such an important topic. And next slide, please. My background, as you said, is that I have some connections to Michigan, and I actually trained at University of Michigan. And my first, my last night on call, in fact, received a call to the house phone where somebody called in and said that Mike, I won't say their last name, is dead. They'd been found in a call room and the person said, you know, they graduated from this program, and I just thought somebody should know. Anybody who's practiced in anesthesia for as long as I have has been impacted by this. And it's such an important topic, not just because of the regulatory and legal oversight to it, but honestly, because of the human impact. And I've seen that personally. Next slide, please. This is a more recent case. What this really brings out, this Mount Carmel case, is that there were potentially warning signs that that had been reported and were not acted upon. So that's one of the key features that we see in not just medication security, but in really all aspects of quality improvement and patient safety, is that we see that failure to act upon risks when reported often can lead to significant harm later. And I'll elaborate on that further down in the talk. But really what I'm going to focus on is how you can think of medication security, not just as a problem for pharmacy or, for that matter, for administration or regulatory, but how you can think of it more as aligned with your overall quality improvement strategies and programs. Next slide, please. The key thing in thinking about the OR, how do we get the OR to do anything, is to think of it not merely as compliance. If you think of it as trying to engage them, and that works so much better than thinking of it as mere compliance. Now, there is a huge regulatory space here. There's no question. The penalties are sometimes criminal in some of these cases, but it's really important that people understand in quality improvement that mere compliance is not typically motivating. And we'll talk about that a little more further down the line. Next slide. Think about what we all had to do perioperatively, but in many other settings to deal with COVID. This is Jamie, who's one of our nurses who graduated from nursing school a year before the pandemic started. And everyone listens to her. Why is she standing outside of the OR? Because she's making sure that no one enters or exits, because we have a COVID patient in there. This is a patient we took care of recently. Why do we do that? Obviously, well, perhaps now it's obvious because we're all quite familiar with this, that if we're doing aerosolizing procedures, which intubating patients is, we don't want the door open because we don't want to potentially infect anyone else. And so she's basically standing guard, but all those things posted on the wall there, those are all policies which she knows, and we huddle ahead of time to be sure that everybody's on the same page. My point here is not that we're necessarily going to be able to do that with med security, because we are literally protecting our own lives in these situations, and that's why this has been we've been able to galvanize people so quickly and engage them so quickly. But when you appeal to things that matter to people, then you're able to engage them much more than if you simply tell them the rules are the rules and why is there pushback. Next slide. So part of this is to have a culture where you have a reporting culture, you have a safety culture, and you have a culture where you're willing to do something a little different than you've done it before. And this is culture, while it's hard to define, people often say it's the attitudes, values, and beliefs which guide thinking and action. The things which influence your culture are often invisible to the people who are there. And this is from a famous David Foster Wallace talk where the big fish ask the little fish, how's the water? And they say, what the hell's water, right? Because they're swimming in it. They don't know. They're always in water. They're not even aware of it. And sometimes the environment that we're working in, whether we're taking the approach, for example, I live mostly in the quality/administrative world right now. It's easy for me to view it as, well, I know all these rules from, say, Joint Commission, or I know these are rules we have to follow. But for people who perhaps aren't living in that space, where they're dealing with families asking, why can't their loved one get into the OR sooner? That's the world they're living in. So that we're often not aware of the environment we're living in, and that's the culture. Next slide. So when we think about culture, we've learned from organizational studies and safety science that there's not a single monolithic culture in really anywhere, but certainly not in the OR. So there are studies actually that show significant differences and more heterogeneity, more difference between units, say cath lab, OB, ambulatory surgery, main ORs. And why is that? That's because there are different surgeons working in them. They're doing different procedures. So even though these are all procedural areas, and when I speak of the ORs today, when I say engaging the OR, I'm really talking about procedural areas, and you'll hear why in a minute. Regardless of which of those areas you're working in, what really moves the needle are peer influencers, meaning that you need to engage people. So there's studies of social influence, and what they find is that cheating on exams is contagious, for example, in certain environments, but so is rule following. And it's really the same thing with a number of other things that we found in safety science. Next slide. Even when we're not talking about something that is significantly, is perhaps harder to define, like culture, where culture is variable. We're talking about something where there is a fact of the matter, like estimating blood loss. This slide kind of humorously gets at the idea that in a given surgery, the circulating nurse, the scrub tech, the CRNA, they all think that they've lost, between 425 and 599, and the surgeon thinks they've only lost 1 cc of blood. Now, anybody who's worked in the OR understands that that's actually true for how things work. And I have tremendous admiration for a lot of the surgeons I work with, but the reality is that none of us are very good at estimating blood loss, so that we've actually moved to things like quantitative blood loss as a safety strategy in OB. But the reality is that even when there's a fact that we're perceiving, there are different perceptions. So when we're talking about something like culture, or something where the risk that we're taking of perhaps violating a procedural rule, or not following a policy, or not being, or there's some level of drift, it's going to be even harder to have equal perceptions of the gravity of that. Next slide, please. One of the things that we learned in safety science is to really not just focus on those tragic events that I talked about at the beginning, such as the Mount Carmel case, that we really need to look at early warning signs of things. So this sign isn't actually how any of us detect a gas leak at our home. I think everybody could say how they know if they have a natural gas leak or if they left a stove on at home, right? It's not because the house blows up. It's because the early warning sign is that you smell rotten egg smell. That's because they've added that smell as a safety mechanism. And the reason for that is we want the early warning sign of a gas leak to be that you smell rotten eggs, not that the house blows up. In medication security, I believe there's an analogy here, which is that we don't want to hear about our colleague who OD'd or is being arrested, that we want to, or even the institution. What we want to do is find practices which are safe and identify early on when there are deviations. Next slide. This is something that is important for any of us to understand with any initiative. This would apply to, say, infection prevention and control, but it also applies to our medication security and medication management initiatives. The perioperative environment really is error producing. In other words, if I wanted to design error into a system, I would create an environment just like the OR. It's rushed, there's crowding, it's either too hot or too cold, it's noisy. Often the teams that come together, they're unfamiliar in many settings, meaning the whole team hasn't worked together. That's especially true with the staffing, but it's always been true. Next slide, please. So to help us with this, in our OR pharmacy at Henry Ford, we have Joe, who's been there for 25 years, and he's just a wealth of knowledge. We rely on him for everything from antibiotic dosing to occasionally, if we have to do complex cases where we're using some sclerosing agent that we're putting on the field and we're not familiar with it, we ask Joe. He knows how to help us, and he helps us with those situations. Not everybody's going to have Joe to protect them in these situations. He's also going to help with medication security. Next slide. The anesthetizing locations, as I talked about, are not just the main ORs. You can just hit click. It's more and more all over the place. This is the biggest growth in procedural areas. We have main ORs, ambulatory surgery. We have OB, we have the OB/ORs, but any room that we do, say, an epidural in, that can then become a procedural area. The ICUs, emergency departments, cath labs, EP, interventional radiology, and so on. You can just see, next slide, many, many locations. This is just one example of what we might call an off-site location, but it's particularly common for providing anesthesia where there are going to be controlled substances. This is MRI. And the thing that's interesting about this is that the MRI suite, you're going to have other folks in the area who know how to run an MRI scanner, but there's not going to be anyone else who knows anything about controlled substances. You're going to have an MRI tech or two, and that anesthesia provider, whether CRNA anesthesiologists, are going to be there alone with their medications. So it's a structural feature that introduces risk. It's not that it's in terms of any number of things. And I'm not just talking about folks stealing medications, but if you're in an OR, and anyone who's worked as long as I have has done this, you accidentally leave, say, a controlled substance out. Most of the time, and no one wants to hear this, somebody will say, hey, you left it out, and we'll tell you. If you're in an area like this, there just isn't that traffic. So it's just a much more dangerous place where there isn't that team to help you. And that's not at all a safety solution to have someone, find your controlled substance that you've left out, but it's just the nature of the detectability of what's going on, which is an important thing. Next slide. Safety culture is really promoted by system design, because if you have it's this bidirectional process where in a safe culture, you're going to design higher reliability solutions. And with higher reliability solutions, you're going to have a safer culture. And these are some keys are to standardize when you can, simplify into task structure, reduce task complexity, integrate solutions into the existing workflow, and be sensitive to operations, and make the default choice the correct choice. I'll talk more at the end about that. Next slide. But who needs to be engaged? Well, as I mentioned, these high-risk cases are not just in the main hospital settings in the core of your OR where Joe can help you. We see the biggest growth of anesthesia cases in these non-operative anesthesia locations and ASCs. And these are often left out of, honestly, not just med security discussions, but meetings of OR teams and procedural teams where key information is meant to be disseminated. So one of the most important things is to have an inventory of all your anesthetizing locations and be sure they're included in any communications related to med security. Next slide. A lot of this might seem like an overwhelming task, but this is from Richard Thaler. It's a Nobel Prize winning economist from University of Chicago. And really it's the idea of nudge, and it's the idea that small changes can really make a huge difference. And I really believe that is true in quality improvement as well. It's the idea of starting with that one step, or not trying to eat the whole elephant in a single bite. Next slide. When we think about safety science, we have to use some level of data, but we also have to have this mixed method where we use some of these anecdotes or narratives that I talked about, right? The story that I talked about, and everybody has one. The data are never perfect, but they do help you. They do help you understand when a change is an improvement as part of your PDSA cycle. You need to understand that to get from mere compliance to engagement, you actually have to have unit-specific level data. If you just go to a series of a group of physicians or CRNAs and you say, hey, our discrepancies are unreconciled discrepancies are too high, they're going to say who, where. And as I've said, the procedural areas are so vast that you need to be targeted a little bit. So you have to have unit-specific data. Next slide. One of the things we might think about from an administrative point of view is we often talk about some of these violations of procedural rules that I mentioned. I gave a pretty egregious example of leaving controlled substances out, say on a tabletop in an unattended OR. We might say, oh, if that goes overlooked or if that's common, that's normalization of deviance. And one of the things that I've learned over the years is that this idea of deviance and pushback are two phrases I really don't like. I think what I like better is, next slide, this idea of drift. And the reason I think of that is because really, when you think about drift, and the reason this talks about agreeing to user license, I mean, I know it's forever ago for all of us, but at some point we looked at what some of these said, and now we just hit agree. And everyone does this. But the reality is that when you talk about drift and you think about user licenses and agreeing to them, it seems understandable. When you talk about normalization of deviance, you're thinking, oh gosh, who does that? And the reality for medication security and for most of our quality problems, it's much more like drift than deviance. In other words, it's not immoral what we're doing at the moment. There are competing priorities that people are focused on. Next slide. And if I had to have a few key takeaways that I've learned over the years in quality improvement that apply to this issue, it's really to understand that leadership's the art of getting someone to do something because they want to do it, not because you want them to do it. Most industries standardize about 90% and then have 10% variation. Healthcare reverses this. Think carefully in healthcare about what you're going to standardize. You need to standardize things that are going to be value added. Standardizing the color of the posters may not be useful. It may be, but that's not as important as standardizing, say, to a single concentration of medications. Culture and context clearly influence individual behavior, and the best improvement, and this I almost want to say as a typo, as I said, when physicians own the problem. Really, if we're talking about perioperative, I mean providers, I mean physicians, CRNAs, and whoever's delivering anesthesia, certainly engaging surgeons and all the providers is key. The real point is in bold is that you need to think of this not as a pharmacy problem, but it's part of perioperative quality and safety. And the key stakeholders have to be the providers. Next slide. Well, what if you're in one of these locations that I talked about, some of these offsite locations, and you don't have profiled ADCs or an OR pharmacist? What are some of the things you can do? And Ryan's going to get into quite a bit more detail in his talk, give a really excellent path to success in this. But some key features that take advantage of some of the high-level solutions would be, for example, to use pre-filled syringes to eliminate hazards related to aseptic technique. You don't have to remember to wipe the vial and draw the smallest dose, so we're not relying on memory there. It also decreases work. Purchasing the smallest appropriate dose, again, minimizes waste and time reconciling. Tamper-evident packaging, again, increasing detectability, good safety solution. Next slide, please. This is ISMP's rank order of error reduction strategies, and I refer to this in literally every Sentinel event I run. And the reason, and I use this all the time, honestly, because we all know how important education is, and this is education that we're doing now. We all know how important it is to have available information, and we all know to be as careful as possible. But the reality is, as an enduring safety solution, none of these are effective. The most effective things are things we're talking about, which are much higher up on this hierarchy of effectiveness. Fail-safes, forcing functions, clinical decision support through automation, standardization, redundancies. Next slide, please. We don't need to convince everybody. There's always going to be somebody in your procedural areas who says that they're not going to buy in, and that's not the idea. The way change works is you have the early adopters, and really what you have to do is get the early adopters and the early majority and work with the willing initially. Next slide. I think that if you're able to do that, you're able to really find some key peers and key frontline leaders that you can align with, then you'll find that you get to this tipping point, which really will help on the journey to improving medication security or any quality improvement initiative. That's it. Next slide. Thank you so much. This is from New York in 2020. I'm going to turn it over to Ryan, who is going to give us an incredible overview of strategies for success in medication security.
All right. Thank you all so much for the great preview and Dr. Pollock just kind of really setting the stage. You know, you and I are so passionate about this topic because at the end of the day, we know it improves patient care and it improves safety. And I think that's what we're always rallying around. And how do we create that value proposition that really gets organizations kind of in the driver's seat, being proactive about some of these perioperative areas and what we can do to improve medication use? And so, you know, this slide, I think, really does develop that management value. So the question comes is controlled substance management requires recognition of safety, prevention, but also the impact of waste and cost savings across an entire organization. And many of us know with the pandemic and kind of based on your recent slide there that, you know, we're being impacted and we're still being impacted by staffing. We're being impacted on how we better utilize our inpatient beds and how we maximize some of our ambulatory perioperative setting to really take care of patients. But at the same time, how do we do that in a safe manner, especially in non-traditional? And so really to develop a proactive, comprehensive, controlled substance program, we've got to have three main tenets. And I believe that first starts with executive support. And I really love that point in your slide that it's not just pharmacy. This is across the organization. People need to see controlled substance management as a safety issue, a cost issue, and a liability. And how do we get many disciplines to the table to talk about opioid stewardship and diversion prevention and cost savings and not just focus on maybe an individual or department? And so I think that's really important. And we do that through shared decision making. We pull in nursing, we pull in pharmacy, we pull in finance, legal to provide a comprehensive plan forward that really gets multiple key stakeholders bought into the process. And lastly, you know, we're part of our financial recovery. We're coming out of the pandemic. We're paying really high expenses for labor. And so how do we provide financial stewardship or create a financial benefit through this kind of prevention of diversion? And I think honestly, diversion increases cost, and that's something we have to monitor for. Next slide, please. Building off the example that you had, you know, with the incident that occurred, we found that University of Michigan had to pay a record drug diversion settlement. And so we see that drug diversion is not only important to patient safety, it's not only important in protecting your license, but it's important to reduce expenses. And so when you're spending millions of dollars in fees by not having a comprehensive medication program, that gives you another, you know, pedestal to step on. And I think that's another key tenet we need to focus on as we go throughout this presentation. We do our comprehensive diversion program with an investment into automation, artificial intelligence, an audit team, waste mitigation practices, and also how do we create changing of practices? We're so used to, we've got to do what's right for the patient. It's got to be fast. We're in a perioperative setting. We don't have time to go through these, you know, separate workflow processes that slow us down. But at the same time, we have to do that because that's what creates patient safety check. And it also, you know, mitigates diversion internally within our organization. So let's first focus on maybe the cost portion of how diversion can impact a facility from safety and cost perspective. And we can build into some more of those safety checkpoints throughout the rest of the presentation. Next slide, please. So quantifying controlled substance related expenses is so important. And my colleague, John Hertig, has published this literature very recently. And I know he's already presented as a part of this series, but I thought it would be great to tie in a tenet of that presentation. And so he focused specifically on a continuous, Hertig and colleagues focused on a specific continuous observation workflow time study to assess IV push. What I think is really interesting is constantly as a pharmacy leader, I need to leverage real world evidence and leverage, you know, very late breaking clinical literature to make sure that I'm incorporating it into my drug diversion program and that I'm being thoughtful of all the different areas that drug diversion is impacting. And I think what he pulled out, him and his colleagues pulled out that was so uniquely is they focused not just on drug waste that creates more liability across the organization. We have to reconcile it. It costs money, right? Waste is drug that you've purchased that you're not using, but also the time and labor expense that gets pulled into us reconciling all of these dispenses. And I know now more than ever before, we're trying to create great employee engagement. We're trying to provide staffing models that are sustainable. We're trying to mitigate staffing expenses. And if we have extra labor expenses that are being incurred because of waste, It's a great opportunity for us to focus on that as well. And it aligns with some of those strategic priorities that many of us are focusing on. Next slide, please. So the goals of a cost-effective controlled substance management, I think, are really almost the total cost of care nowadays. So we know that acquisition cost is important, something we always focus on. It probably hits pharmacy's budget, but total cost of care, thinking of all the different spectrums that waste and drug diversion impacts, I think is even more important. So we need to understand, what is appropriate management of waste? How does it impact medication safety if we're providing vials that have more drug in them? What if that vial gets used again? What if someone doesn't use great aseptic technique and we have some type of infection? I think these are really important to think through as we go through this rest of this presentation. And we know that labor can be decreased. And if we can decrease labor, we can decrease organizational spend and create more lean, effective workflows. And we're better utilizing people's times. So many times, I think my job in pharmacy is to complement my nursing colleagues and make sure they're practicing the top of their license, providing bedside care. And so I think that's what we're trying to monitor is how do we balance, right? That total cost of care, those labor worked hours, that excessive monitoring that we need to do to promote a comprehensive drug diversion program, but also making sure we're providing improved safety, better utilization of our team members, and better utilization of an appropriate dosage form. Next slide, please. So direct costs are related to controlled substances. Each waste activity requires labor of a nurse or healthcare provider. It requires a waste of utilization of services within the pharmacy department or the drug diversion and compliance department. If we're having to follow up on every single time there's waste out there that's unreconciled. And if dosage forms are not optimized, each unit of waste leads to additional expense. So again, if we're using a 5 cc vial and we're only using 2 cc's, we're basically wasting more than half of that drug, but we're paying for all of that drug. And so how can we optimize the dosages that we're currently utilizing? Next slide, please. So there's also indirect impacts of medication waste. And I've talked about hard dollars, as my CFO colleagues would refer to. This is probably those soft dollars, but every time we have to document waste, we have to have a witness. And so we have increased documentation and witnessing of controlled substance waste. So not only is that nurse that's taking care of that patient, potentially it might be a high-risk patient, and maybe there's tripling that's occurring due to inadequate staffing levels or inability. And so then they have to pull someone else that's tripled to go waste with them at the automated dispensing cabinet. And so, wasting and independent wasting is really important. It's an essential piece of a controlled substance program, but it's also utilizing worked hours that if we minimize waste, maybe we don't have to keep pulling people apart. It doesn't require pharmacy follow-up and reconciliation. And the last thing I always think about is when Joint Commission comes on site, people are pulling up doses out of vials. Are they doing aseptic technique? Are they doing appropriate wiping? Are they labeling that syringe or administering right away? And if they're not, they're introducing risk to the system. And that's something we have to be thinking about. And then lastly, it's the risk to the healthcare provider. The facilities we talked about earlier, University of Michigan and University of Massachusetts and others have had to pay really big fines because they didn't have great controls in this area. And they had areas where diversion was occurring. Next slide, please. So another thing that we want to focus on when we think about waste is the pharmaceutical waste management. So in August 2020, when we were all very busy responding to COVID and responding to the pandemic, the EPA came out with a statement where they've banned the sewering of controlled substances under RCRA, or Resource Conservation and Recovery Act. The DEA additionally now requires controlled substances to be rendered irretrievable if waste after administration occurs. So what does this mean? So back in the day, when we used to shoot, drug waste down a sink, or we used to do something like that, there was a quick mechanism that we had that's no longer going to occur. So I'm sure it's great that we're not going to have fish swimming around with 3 fins, or basically being able to test the water that opioids exist. That's really important. I think that's the right thing to do. But when we do that, we also need to know that now we have to have areas where we capture all that waste. We have to have mechanisms that render that waste irretrievable, so someone can't break into there and draw up drug and divert, and at the same time we can't sewer it. So that kind of introduces RX waste disposal systems, the right thing to do. But then, and as we render the healthcare medication irretrievable, we have to pay for those. And as they fill up, we have to replace them. So we're introducing now even more cost to the system. So waste generates waste of money, it wastes time, and it also wastes valuable resources in the hospital that we're trying to really create a lot of evaluation around. So next slide, please. So when we talk about all this waste, I think it really sets up the stage for things that are going on right now. And people can say, the pandemic's over and we're kind of transitioning out of the pandemic, which is a great thing. But we've treated a lot of patients. We'll continue to treat patients in emerging treatment locations. What does that mean for a perioperative setting? Think about ambulatory surgical centers. They're located throughout, the different areas. They might fall under the physician group practice at a hospital or health system. They might fall under the hospital-based, but a lot of times they're not directly connected like our inpatient OR is. And I think those are things that we're thinking about constantly. It's typically a fast-paced environment. Patients are coming in, they're going home. Patients have this different mindset when they approach an ambulatory surgical center that it's really kind of an in and out. I want to be treated at the time of my appointment. And with that, though, because there's all these different centers, there's not great connections. There's not great budgets. Sometimes they're operating more in a lean budget. Then you're typically going to have less automation and controlled substance oversight. You're going to have medication documentation that may not be in the EMR. It may not be tracked within that artificial intelligence system, but it may be written in where that surgeon might be documenting the doses, or anesthesiologist within a paper chart of what they gave, and not necessarily on the MAR that can be tracked back to the electronic medical record. We know that reconciliation can be really difficult. If we don't have really good waste techniques, someone can't just walk out to an Omnicell, or maybe there's not a ton of automated disposing cabinets or Pyxis or whatever brand you want to refer to. And so how are they reconciling that waste in a timely manner? And how are we making sure that they're reconciling that waste? And we know that controlled substance storage varies by location. It might be in an automated dispensing cabinet. It might be in a double locked cabinet. It might be in a cart that rolls into the different rooms. And so we have to be really thoughtful about those emerging treatment locations and not assuming everyone's doing the exact same as it occurs in the inpatient area. Next slide, please. So we have to trust but verify. And I mean this in my ambulatory locations because we have to walk those perioperative settings. So patient care was cited as number one of the reasons that people want to use workarounds, or why they don't want to utilize anesthesia workstations, or why they don't want to use automated disposal cabinets. And that's understandable, but we have to balance that, right? Because a lot of times in these surgical centers or in these perioperative settings that aren't attached to the main hospital, you might have different individuals submitting the buyer. You might have individuals going through and doing those blind counts, or reconciling the inventory that's available in more of a Kanban system in a cabinet, not an automated processing area. So how do we make sure that people are reconciling that on a constant basis to really minimize any of those diversion opportunities? We know that procedural areas historically lack automation. We like more just in time. Someone might say, I don't have time to know a procedure if something was wrong to go to automation. So we have to create these checks and balances and accountability, and we have to try to back them up. And no diversion problems are detected. If you have no diversion going on, or saying, man, had any cases, there's probably a bigger problem that's brewing. Because when you look at literature, there's this constant evaluation of diversion, and you need to make sure that you are having good checks and balances. And if you're not catching anything, it's not always a good thing. So think about that as you approach your different key stakeholders. Next slide, please. So we got to have this culture shift, and I think that's the most important piece to what we're speaking to today. We have to have a comprehensive overhaul of the programmatic oversight involvement. We need to engage hospital leadership and the C-suite sponsors to recognize it takes more than just pharmacy. And you heard Dr. Pollock and I really indicate that, because it's got to be a medical center, a practice, a leadership engagement, and not just one department. You need to perform a gap analysis and really recognize what are those leading practices and how do you bump up against those, and what are those misalignments. And then once you find those misalignments, developing an action plan, and you have to determine risk stratification. Not everyone's going to have capital dollars to go buy automated dispensing cabinets across all their ambulatory or perioperative areas. It's just not going to happen. So how do you create a risk stratification process where you can at least minimize the risks that exist based on the products you purchase, based on the administration techniques, based on the order sets, based on the disposal processes, or based on the witnessing, so you can maximize value to the organization. And then lastly, identify that team to lead the initiative. Make sure it's multidisciplinary, and think about what additional or repurposed positions could be utilized to accomplish this type of work. Next slide, please. So we want to think about engaging that health system leadership. And when we think about that, we've got to ensure that culture of continuous compliance is embraced. We can't make sure people know that steady state is not appropriate. We've always got to be looking forward, always got to be constantly improving on our processes, because unfortunately people at Diverting are doing that. And also we know there's always better ways of doing things. How do we learn from our colleagues? How do we leverage best practices from organizations like Ismp to make sure we're providing the best and the safest care for our patients? We need to make sure that we have support to invest in several strategies across the organization. You might say, well, how do you invest in that? And when things cost money, well, that's where you come up with cost-saving strategies around waste and labor expense, so you can offset those costs of introducing more safe processes or automation or diversion prevention within the organization. You want to have accountability for drug diversion that goes past pharmacy. How do you identify smart, measurable goals or measures of success that can be reviewed or reported out at procedural leadership meetings or chief quality officer meetings? And how do you have consistent executive summaries that are available to hospital leadership so they know how we're tracking? it's not always good to have green in every area, right? You start to have this tiered huddling and you start to have your daily readiness. How do you have medication safety and diversion be a part of that? So people are getting real-time feedback on how things are performing, and real-time changes and accountability can occur. And lastly, you need to include supply chain and finance, because finance can reconcile, why do we have a greater purchasing with this drug versus others? Why have we shifted the drug we're purchasing? And how can supply chain work to ensure supply guarantees or focus on purchasing on that same NDC so we create predictability and standard work among our clinical practitioners? Next slide, please. So prevention really occurs through education. We've got to create education throughout the entire organization. How do we create annual competencies around controlled substances diversion? So people are learning that, they're checking off, they're going through diversion education annually. Do they do it upon hire? And how do we incorporate controlled substance education into the patient services orientation? So when I think about myself, when I show up to our nursing orientation, all new nurses go through a patient services orientation. And how do we get someone there that talks to them about the importance of diversion, talks to them about how we're monitoring it, and talks to them about the importance of following policies and procedures to create safety for them, but really to complement their practice so they can have less risk on the work that they're doing if they follow the process, right? Because I think one of the biggest things we've learned, especially recently in the news, is patient safety is dependent on reliable, predictable systems, not individuals. And if a system's not designed right, it can create an individual error. But if we want to focus on the systems, and how can they give us feedback so that we continue to do that? Next slide, please. So the other focus area is the art of perpetual inventory. When we're looking at all these different areas, how do we make sure that we're accounting for every dose, from order generation when we submit that order to when we receive it? And I think that's really important. We want to make sure that controlled substances have specific generation. We've identified the medications that should be ordered, the ones that aren't. There's blocks in place, right? Or additional approvals that are needed, and that we reconcile the PAR levels. If there's a ton of controlled substances at one perioperative location compared to others, does that introduce more risk where people can divert? So those are different things that we're thinking about. Next slide, please. And one of my favorite topics is the traceability. When you want to have transactions occur, if possible, through automated dispensing cabinets, you want to have direct hand delivery of non-automated dispensing cabinet drug, and you can have signatures for that. So there's some reconciliation of dispense. And you want to make sure that all issues are documented if they do come up so that proper follow-up can occur. And then the reconciliation, you want to make sure you document waste within the system, create a witness so that no one can create diversion all on their own. And you want to have a controlled substance administration record tied to the patient medical record so that you can link the two. And then lastly, just always make sure that you're linking the employee to the patient. You're looking at doses that are given too early, too later, and how are you reconciling overrides and making sure you're minimizing override capabilities as much as possible. Next slide, please. Another one principle that I think applies to so many areas, but especially the perioperative setting, is how do you create strategies for internal control? So we've talked about safety to our patients, safety to patients diverting or giving the wrong medication, but internally we need to make sure that people can't divert. We have to protect our employees. And one of the great ways to do that is segregation of duties. We limit who can order medications, but also we make sure that there's not the same person ordering is receiving, because anytime one person's doing multiple activities, that creates an opportunity for them to divert and it not to be caught. So how do we create segregation even at the smallest ambulatory surgical center to the largest perioperative setting? And how do we make sure that people are periodically reviewing and auditing that to make sure that purchasing patterns are consistent, there's not any abnormalities, and if they are, they can be reconciled and documented within that process. Next slide, please. And so this really just gives you an idea, I think, of that segregation duties. I always like to create visuals in my presentations. We want to reduce the opportunity for diversion and concealment. The order can be proposed by validated PARs. So you establish the methodology for which the amount of drug you're going to purchase. Everyone agrees to it. They understand the background to it. And then you utilize those validated PARs to order drugs. So if someone's wondering why you ordered so much or so little, you can go back to your PARs. The perioperative buyer can review and submit that order, but then a clinical leader actually signs off on it before it actually gets fulfilled. Then a different individual can receive the order, and they're going to look at that and say, okay, what came in off the loading dock versus what was ordered? And that gives that opportunity to say, hey, are we missing medication, or did something get taken in between the process of us receiving this into the perioperative setting and the process of it being ordered? And then make sure you're always looking at PARs and you're updating them and reconciling them based on the run rates of medications within the area. Next slide, please. And so oversight within the perioperative setting creates separate practices. so that you don't just have drugs sitting on a receiving dock, it's delivered directly to the facility. De-identify controlled substance shipment, so people don't know, oh, that's the controlled substance order, I'm going to go check that out, right? Limit the individuals and establish robust camera and surveillance so that if you ever need to look into it, which unfortunately you don't want to, but if you ever need to, you can not only do it through some of this tracking, but you also have visual controls that can give you further context to the individual situation. Next slide, please. And so you want to have oversight within the facility. Great electronic and physical matching. This really talks about that order, invoice, and purchase order, and make sure that the order that was generated matches what you ordered. What you ordered matches what you've received, and what you've received is actually put into the cabinet and reconciled based on that blind count. And I think that's the way you establish just processes, no matter if it's automated dispensing cabinet or not, where you can pick up on diversion when it's occurring within that value stream. Next slide, please. So safe handling of controlled substances, I think of these best practices. You want to use the smallest dosage form possible to reduce waste, to reduce medication error. You don't want to give a 5 cc vial if everyone's only using 2 cc's. Can you get a pre-filled 2 cc? Can you get a 2 cc vial? Those are the things you want to be thinking about. And when you're in these perioperative areas or ambulatory surgical areas where you may not have automation, how do you have medications that are maybe ready to use? You don't have to worry about people using appropriate aseptic technique, or they have some type of packaging that's tamper evident. And I think those are really important as we go through that. And then if possible, we know the drug shortages, try to utilize the consistent NDC. So you're ordering that same drug. So if you start to see purchase orders for the non-NDC and there's no shortage, you may wonder what's going on there. And people are used to the same processes and standard work based on the medication product. And avoid sending up bulk dose forms, because again, it allows people to go in and do too many retrievals that violates United States Pharmacopoeia of sterile compounding or just-in-time compounding, but at the same time, it allows you to mitigate any type of diversion from those bulk dosage forms. Next slide, please. Proactive and process review. Remember to be proactive than reactive. Select a third-party software. That's why I talked about the artificial intelligence that can pick up on purchasing strategies, administration strategies. You can compare like floors together, and then you can figure out who's going outside that standard deviation, what's being ordered that really shouldn't be, who's administering a dose at the highest pain scale every single time versus all their colleagues. And those are ways that you can start to create robust data fields, and then the system becomes to learn. Now, we know that bias is inherent to artificial intelligence, so that can't do it alone, but it aids you and creates efficiencies when you're monitoring all the different areas throughout the hospital, health system, or perioperative setting. Next slide, please. And so in summary, as I'm starting to finalize here, think of your gap analysis. Focus on the different areas: procurement, dispensing, prescribing, administration, waste. Think about all these kind of nodes where diversion can occur, and bump up your practices versus this gap analysis. How does it work? And you might say, hey, we've got some opportunity in procurement. I'm going to do a deep dive. And so on the next slide, you'll see an example of, once we go, next slide, please, to jump into procurement, we're going to start to see, okay, well, if I focus on procurement, now in the ambulatory perioperative setting, is everyone authorized to procure controlled substances? What are the checks and balances? Am I compliant there with best practice? So that might be complete. Is there segregation of duties? Oh, maybe there's not. The same person ordering right now is receiving. What can I do to extract that information, or who can I pull in to receive? That can always be double checking what was ordered. And how can I get automated technology, and how can I budget for this? And those, I think, are really key principles that you want to think about as you go through your gap analysis. Next slide, please. So evaluate the gap. Look at your order methodology. Look at the location of the order with which it's received. Is the order content verification, can that occur appropriately, where you take basically the order generation versus what comes in the box or what comes in your delivery, and then you compare them two together? Are there proper blocks where not everyone can order controlled substances on the wholesaler accounts? And lastly, as you're receiving the order, what is that process for it being put up in a timely manner? Next slide, please. So, as we go through here, and Jordan, you may just want to click through, I think, just a few times more, but you want to leverage the reports of automated dispensing cabinets, because we want to utilize this data to say, what's the financial impact? As we start to provide this safety context, what value does that bring back to the organization? Because the organization might be spending money to get some of these systems in place. So leverage reports from your automated dispensing cabinets, identify those medications where maybe there's a lot of waste. Is there an opportunity to purchase a lower dosage form? That's going to save us money on the purchase. It might save us money in terms of how much waste heat in those waste containers we're buying. And it might save labor expenses, which we know right now is probably one of the most valuable saving opportunities for us as a health system. We want to identify waste events and kind of create that labor expense. Leverage some of the data from Hertig and colleagues to quantify how much labor are you expending just on people wasting because you're buying products that maybe don't match the dose that should be given. What is that total drug waste by ml, and how do we extrapolate that? And I think that's the last piece, is putting all these different metrics together. So next slide, please. As we start to propagate this, we might look at expense per ml. We might look at the number of doses wasted and what is that total ml annualized. We get an expense there. What's the workforce expense if we're spending 73 cents in labor expense just with reconciliation? Well, that data he published is several years old. So now it's probably $4 per waste event just in labor expense of someone stepping out to reconcile. And how does that build a value proposition to invest in better safety techniques, better software, better products that complement the practice of the patient and promote patient safety? Next slide, please. So in the end, I really want you to be thoughtful. Consider the total cost of care. Consider the acquisition cost, but more importantly, the total waste and the impacts of that are generated throughout the organization. This is not just a pharmacy, just a nursing, just a physician. This is everyone coming together to bring value back to the organization. Aim to decrease those waste events, leverage your internal data, and make decisions, those gap analysis to evaluate cost and gaps throughout the entire medication delivery process. Next slide, please. So key takeaways: create medication order sets. Make sure those order sets can match the dose. So you create really good efficiency and safety there. You're not creating order sets with doses. You're dispensing, that 5 cc dose for a 2 cc dose every time. Consider your purchasing and ready-to-use dosage forms that create less burden on that caregiver and also allow compliance, right? We want to design systems for success, not reliance on individuals. And utilize 1DC if possible to just consolidate product use. But we know there are some exceptions to that with some of the shortages. Next slide, please. And I think create cross-discipline. I've said this a lot. I won't focus on it more, but make sure it's not just one discipline. Come together. Executives now want to see multidisciplines creating value, bringing cost savings ideas. And I think right now, controlled substance diversion plays such an important role to safety, cost savings, and minimizing risk for the entire organization. Next slide, please. So putting it all together, because I got to finish up here because I want to leave time for questions, but make a conscious decision to take action. Engage those key stakeholders early, consult nursing and others on these shared goals, these cost savings, review costs that exist outside of just pharmacy alone. How does it impact staffing? Leverage internal data to create data-driven decision-making that's consistent to the organization. Optimize your purchasing and your administration techniques, and make sure that it's joint advocacy. Everyone's coming to the table to the executive saying, we got to focus on this. Here's how we do it together. And here are the cost savings across all of our different departments. Because changing an organizational approach to controlled substances takes a team, and it takes executive support to get there. Next slide, please. So with that being said, I'm done, and these are some of the resources I had. I'm actually going to turn it over to Susan, who's going to facilitate a Q&A with the remaining time in our presentation.
Thank you so much, Ryan and Ed, for some great insight into some of those diversion issues we've got. So I do have a few questions here, if I may. And Ryan, you may want to take this first one. What would you say is the most difficult challenge or maybe a barrier to aligning some of these strategies you spoke about, between those organizations that have both inpatient and procedural areas? We're looking there in terms of those barriers.
Yes, Susan, that's such a great question, because so many times, so many people will say when we start to roll it out, a lot of people in the inpatient and perioperative settings will have no clue what's happening in the ambulatory. And the ambulatory will say, we're not like the big house or main campus. You can't treat us the same way. So sometimes there's a lack of appreciation for the different workflows, and we've got to come up with individualized practices that may not be the exact same, but principally they're trying to attack and approach the diversion prevention and safety context the same. So for our ambulatory areas, they may not have automated dispensing cabinets, and people in the inpatient perioperative setting say, well, why not? Well, it's costly. They're used to just in time. And so creating maybe a manual storage facility with a prepackaged medication that might cost a little more, but it's going to promote safety, is going to be an appropriate status there. It also may come down to people in the ambulatory setting say, you can't have all those controls. We work much faster and much leaner than main campus. Well, we recognize you're a just in time and you're trying to do what's right for the patient, but you do have to establish some type of oversight. And how do we get your buy-in, and what does that meet in the middle? And I think those are some of the biggest barriers we've had initially, and creating really good principal drug diversion and medication safety practices, not just in the inpatient perioperative setting, but as we roll that out to these more emerging ambulatory settings.
And And this again could be for either of you. Could you talk a little bit more about the metrics that maybe you report up to leadership, just not to pharmacy, but actually to leadership that might support some diversion prevention? What sort of metrics do you believe are really key for leadership?
Maybe I'll get started, and then if Dr. Pollock wants to chime in, one of the things we focus on is where's our biggest need, right? So where's our biggest risk? How many discrepancies in our automated dispensing cabinets are being reconciled? How quickly are they being reconciled? How many medications are being administered outside of the time window for that medication administration? People doing it after a patient's been discharged, before? How many individuals are falling outside the standard deviation of appropriate medication use on their unit? And lastly, how many false positives, meaning we catch someone, or the system might indicate they might be diverting, but when we look into it, they're really not. And I think it's all going to depend on the organization, but in the perioperative setting, I think those are different things that we focus in on because they're areas for opportunity. And if you're constantly improving, like I mentioned, you're always evaluating those measures of success. And as you start to do really well on them, you don't forget about them, but how do you introduce new ones where you have more opportunity to improve? Because what you measure is usually what people watch, and what people watch is usually what they comply to. And I think those are principles that have been really stood out for us. But I'll turn it over to my colleague to answer also.
So I agree with all those. I think the other thing that you don't want to dismiss are your anonymous reporting system. I realize that people often don't consider that true data, but the reality is that often that's where some sort of abnormal behavior is reported. And it can be as simple as somebody that's going on break unexpectedly or is too long, things like that. And so in many cases, you need to put some sort of a narrative and connect it to the data. I completely agree with objective measures as well, but I think you need to look also at your anonymous reporting system.
And Ed, there was a question about, and I'll put this to you because it's about addressing outlier practices by anesthesia providers that often explain things away by saying they have different practices.
Yeah, I mean, I think that that's such a challenge. I think that that's where it's important to figure out what are the non-negotiables, right? So if we're talking about, are you talking about, it's tough in this setting to answer a question with a question, but let's assume that you're talking about, for example, the amount of controlled substances used per patient, right? So you have somebody who's a real outlier and they say, well, I just practice differently. If that's what you're talking about, I would say that, most of these audit trails, the point of them is to raise a question. It's not going to give you the answer. So you need to also then look at whether it's plausible or not. You need to engage your you need to obviously engage your anesthesia leaders in that. Hopefully they can help you with whether this makes sense, but you also need, as somebody who's kind of worked both on the inside and the outside of anesthesia, you need to have a little bit of a critical eye to it as well. So I don't think we want to just say that because any more than we want to say because the surgeon said there was only 1 cc of blood loss, we believe it. We don't want to say because the anesthesiology, department leaders say that this is all normal. If it's 10 times the doses being given that everybody else is given, we can't just say that's normal. So kind of a long answer. There's not a key, there's not a single answer, because at the end of the day, the real answer to that is leadership. I mean, that's really what it is not to just accept that, but it's not a simple thing.
Thank you, Ed. There's a question here also that sort of a statement and a question. So this individual works in a facility in Montana. They just implemented a medication regulatory specialist position who's a certified pharmacy technician. And part of this individual's role would be diversion monitoring, among other things. And just curious if you've heard of any locations or have experienced similar positions in your work, and any suggestions you would have for a role like this.
Hey, Sue, I think this is such a valuable work, and kudos to you in Montana for leveraging the role of pharmacy technicians, because I kind of call them the MVPs of the pharmacy world. And I think they have so much intelligence and so much opportunity to keep growing their role, and controlled substance diversion and prevention is one of them. And I do think that you have to be very mindful about how you're going to create standard work. How are they going to reconcile and what the work that they're going to be doing? Think about leveraging some type of artificial intelligence or software, because you want to minimize the amount of time they're trying to just run around and chase things, but you're optimizing the work that they're doing. What is some of that standard work? What are some key measures that they can reach out to that doesn't require them just following up on waste all the time? And how do you have automation that does a lot of that frontline review, but escalates things in kind of a risk stratification way so they can focus on what needs the attention the biggest? I think those are key principles to allowing this person to be really successful in their role, and also to be successful in identifying diversion and having kind of that appropriate time to investigation that you need in order sometimes to be successful and prevent it in the future.
Seems like a popular item. See lots of information in the chat here about similar roles. So thank you for addressing that. So unfortunately, we are out of time, but I really just want to thank again Dr. Ed Pollock and Ryan Hampchild for joining us and giving us such insight for today's program. We'd also like to extend our sincere gratitude to Fresenius Kabi for supporting this program. And lastly, but certainly not least, thanks to you all, our participants, for joining us today. And we hope to see you on the next Ismp webinar. This concludes the webinar.